Today's webinar is focusing on Alabama Medicaid demographics and its population summary. This is just a broad overview from one calendar year's worth of claims data. It's not intended to go deep into financial or individual usage. It's just kind of an overview of what the population looks like, what we're looking at the RCO populations and how they currently are using the health care provided and the prescriptions, where they're seeking care, and things like that. With us today is Chris McInnes, Director of the Data Analytics Group, and he's going to provide most of the information. So, Chris?
Thank you, Drew. So, I'll give you an overview of our outline for today. We're going to first talk about the geography, just to make sure everyone understands the areas of the RCOs, then go into what populations are being included in the regional care organizations, the demographics of those, and then a pretty high-level cost overview of the regional care organizations by some of those demographic groups. And then we were requested to provide some cost details around emergency room, professional, inpatient, and pharmacy utilization. All of this information is based upon calendar year 12. No attempt to project or alter the data has occurred. The population is filtered based on the current plans for the RCO population and may change. Claims data has not been filtered for included or excluded services, and some services included in the data may be excluded from RCO responsibility. So there are some costs that are outside of claims. We've not included that, and there are some claims expenses that we know are probably going to be excluded from the RCO, and we've not attempted to do that. You'll also see some other things. This is that 2012 data based upon this population for that time period. We want to make sure everybody kind of understands that from the beginning. First, the geography. I don't know much to say on this. This is the same map that has been displayed elsewhere, but you may want to look to kind of see in your area which letter corresponds, because from here on out we don't have names for each of these areas. They're named according to the letter that's provided. And so you kind of see from the north with A, the Birmingham East is B, the West Alabama is C, Southeast Alabama is Z, and the Mobile area is E. Want to know who is in the RCO population and who is not. And so as of right now, the populations that are included in the upper left-hand corner include the ABD, the DCCTP, the Medicaid low-income families, refugees. The majority of the population is the SOBRA children. There is the maternity, and there's a transitional. The right side lists the population that are not included in the RCO. You'll see the largest group is the Plan First group. It includes generally, with Plan First, all duals, long-term care, and many of the populations that are in some of the specialty waiver programs and foster children. But you'll see the specifics listed there. The two pie charts on the bottom left show the population of the entire Medicaid population on the left, the recipients. The red area is the percentage that would be in the RCO, and then the other two areas are the ones that may be added in the future, or there are no plans to be added. So, rough guess, about 2/3 of the population looks like it will be included in the RCO. The pie chart to the right is the same color codes, but that goes over cost, and that's claim cost. And so you'll see just a little over half of the Medicaid claims cost would be included in that population. We want to take that population that is being included in the group. You'll see in the upper left-hand corner a chart that shows by RCO how many people are in each, would have been in each group in 2012. That same information is then provided in a pie chart in the upper right-hand corner. One thing that you'll kind of see is that pattern that's shaped by the different sizes of the RCOs. You'll notice that they're not all the same size. That kind of pattern you'll see throughout this as we look at cost and other breakdowns of populations. You'll see that because a lot of our costs and a lot of our utilization is based upon population numbers, and the distinctions are much smaller than the population differences there. On the bottom left, you'll see pie charts for gender, male and female, We do have a small number of unknowns, and that's pretty consistent from RCO to RCO. You do see some distinction in the race groups. 7 is unknown, B is black, C is Caucasian, and H is Hispanic in that group. So you do see some differences among the RCOs in the racial makeup. The top row of pie charts is age groupings. You'll see that a large percentage, I think about 75% of the population in the RCOs are children. There's the under 1s, the 1 to 12s, which make up about half of each chart. The 13 to 17s and the 18 to 21s, that's the large percentage of the population right there. And then you can see how the other groups kind of weigh out from there. And there is some change, but not a huge change from RCO to RCO. The next is the word aid bucket literal. That is the, we are grouping the people, and you saw this on a previous chart. And one of the ways we group our descriptive groups of the different populations that are included is what we're calling aid bucket. It's their aid, what aid category they're coming into Medicaid with, and then we're putting them into different buckets from that. And so the 4 primary aid buckets that are included in the RCOs, this is the distribution of those among the different areas. Not much change. You'll see that there is some difference in the size of the MLIF population and the sober population in some of them. If we apply that same population to cost, you'll see the same general structure in the upper left-hand corner for the amount of money spent in each one, from $1/3 of a billion up to $0.69 billion a year. And thrown through that chart, and then you'll see that same in that pie chart in the upper right-hand corner. We then went and got the average monthly cost in the bottom left-hand corner, and I want to remind you again, this is not an actuarial analysis. This is not a detailed financial analysis. That is a much more complicated piece, and so there are some inflation factors. There are some things that need to be added, some things that need to be taken away from these numbers before these numbers would be used for any financial purposes. We've created this presentation specifically for informing the quality group and looking at quality measures. And so we wanted to include these cost structures, but want to make sure that caveat is on everything that we do. So if you see a number here, once the final actuarial numbers come through, there might be different. This is a different type of analysis.
One thing you will notice, though, on these is no matter what the population is per region, they all average about $250 per person per month. So the utilization of care, the total cost of care, is about the same for each of the regions. There's not much difference between the two.
On the bottom right, we included a chart that breaks down into what we call different claim types. There's inpatient, which is in pharmacy, which are pretty self-explanatory. Professional costs, which is a big bucket of doctors' costs, labs, so lots of other costs that kind of come into that. And then outpatient, which is majority emergency room costs, but does include some other outpatient hospital services are there. And you can see how those, how the costs in each area break out into each of those claim types. We've broken cost out by age. First, I'll point out the chart on the right. We didn't see a huge difference in the population's age mixture among the RCOs. And so to kind of give you a reference as to what the age populations were, the chart on the right is the percentage of months eligible by age as part of just the population inside the RCOs. And then the set of charts on the top is the cost by age group, and so you can see what percentage of costs come from each age group, and you can compare that to the percentage of the population they are on the right. And then at the bottom, we did the average monthly cost by age group, so you can see that the under 1, the newborns are more expensive than the other children in the group, and then generally as you get older, with that exception, the cost increase. And compare that RCO by RCO.
You'll also notice that on the bottom, as you age, you expect to see that larger cost. But look at the amount of money that's spent on the less than 1. Even though they're only about 5% of the total population and they average about 10% of each of the each of the RCO's total percentage of spent, they are much more expensive. So looking at the ages, we have a larger children population, and we're also spending more on the youngest of them.
We have the same general chart for those 8 buckets, those different groups. So you can see those different populations, kind of where they're coming, and you can see that the ABD, the age-blind disabled population, has the highest average monthly cost. You can see where the costs break down into different groups and where those populations are. So you see that the sober child, for example, is about 67%, about 2/3 of the population, but it takes up between 37 and 43% of the cost. We then went into some specifics to look at different diagnoses, where some of the specific expenditures going. And so this first is based on emergency rooms. The chart in the upper left-hand corner shows emergency room, total emergency room cost for each of the different RCOs. Then you can see how that breaks down by gender and by race. Some of those breakdowns just go along the different population changes, but there's some other changes that go along with that. The bottom left-hand corner, you'll see we're based upon primary diagnosis, and this is the primary diagnosis reported in the claim. There may have been other things that happened, but you'll see both the primary diagnosis, the total amount paid for this, and that is for all RCOs statewide, but just the RCO population, and then the number of recipients that were involved with that. And then you kind of see how that breaks it down by those 8 buckets and age to see what groups. And so the group, and it's the largest population, but the group that had the largest emergency room utilization was the 1 to 12s in total dollars. That's not weighted by anything. Professional expenses is a pretty big bucket, and I was trying to find a way of explaining what and where these expenses are. And so we did the same general guideline, but instead of using a diagnosis, we instead utilized the place of service. And so this is where, on the claim, as is reported to us, the provider said the service occurred. And you'll see that the largest number is the office claims. And so there's a large number of these services that are provided in the offices, but also included in this are inpatient hospital, so the physician that sees you when you're in the hospital and bills you separately than the hospital, that would be included in this claim type. There's also charges from community mental health centers, emergency room, outpatient hospital, and many other groups. It's a long list, but these are the top ones, and you can see the number of recipients. So a good part of that is office visits, but it's not entirely office visits. There's a very significant portion that occurs outside the office, inside of professional services. For inpatient costs, we did the same thing with went back to the primary diagnosis. One thing that really stands out is the cost associated with the under 1-year-old. That is the cost. That's the 2 top primary diagnoses that are associated with that age group. And you'll see that chart on the right. You'll see the under 1-year-olds with the highest cost group among this, even though they're a small percentage of the population. And so there's a big indicator there, but you can kind of see how the inpatient costs are spread around throughout the population. I have 2 slides, final slides on pharmacy. The first is grouping pharmacy by AHFS class. AHFS is just a grouping of drugs. You'll kind of see from the top one being atypical antipsychotics. There are many drugs inside of that group. It's just a good way of grouping lots of drugs that are similar together, so you can kind of see where the dollars are going. And these are the top ones. That grand total is the total of these, not the total of all pharmacy costs. But you'll see that atypical antipsychotics are the most expensive, and with the amount paid, you can see the number of recipients and the number of claims there. And as you go down, you'll see some that have fewer recipients and some that have more recipients, even though the cost is getting less because some of the medications are more expensive or less expensive as you go down the chart. And finally, we did a similar for the prescriptions, and this is a really good place to point out just remind you what I said at the beginning, that this is 2012 information. Singulair, which is the second most expensive drug in 2012, went generic in August, I think, of 2012. And when it went generic, its cost was reduced significantly, and it fell off the chart. And so that's one of the ways you can kind of see that things do change, and we can't project how they're going to, what's going to be included, what's not going to be included several years from now at this point. So as we look at this, you can see the most expensive specific drug we pay for is Abilify, and you can see down the list the different drugs that are included with the total amount paid, the number of recipients, and the number of claims that were included. Again, all of these costs have been associated with just the population that's included in the RCO. And those that were excluded, their costs were excluded from this. But this is only the claims cost. It doesn't include any other costs that were to come in. I'll open it up for questions, and I can scoot back to previous slides if anybody has a specific question. If you'll raise your hand on the screen, I'll try to unmute you from here, and we'll see how that works.
One thing, we are recording this webinar, and we hope to have it posted on a website along with all the resources we're working on that we've been providing to you during the weekly emails and through our meetings. Like we said, we want to give you kind of an overview of what the populations are, because I know that was one of our bigger concerns with a lot of our members, was simply, if we're supposed to be picking metrics, what are the metrics and who are the populations we're picking these for? As you can tell, the vast majority of the populations that are in the RCOs are those who are the younger. They are children. There are a lot of money spent on the under ones, even though they are some of the smallest group of the populations. But please ask us any questions that we might have. I think you were asking if there was a way for us to better look at different the ages and the age buckets. We can do that. If you had a specific one you were looking at, if there's certain, we can go into the data. These are preset slides, but we do have the ability to look at them a little bit more carefully if there were specific questions you'd like to look at, certain age, if there was a certain region, if there was a certain group that you were looking at, like what are the diagnostics or the number of emergency room visits just for the ABD populations. We can do that. We just want to provide you a brief overview of everything right now.
I think you also mentioned diagnosis, and yes, we can. So we could limit this to this same kind of analysis for those that have a mental health diagnosis from your field, or even more specific to with a bipolar or schizophrenia or whatever specific diagnosis we needed. That was a little beyond the scope of what we thought would be appropriate at this point for the quality presentation, but that kind of information is available.
Thank you.
If you have any questions, feel free to call or email me at any time, and we can also look at some of the other numbers if you have any specific questions.